السلام عليكم حياكم الله جميعا. Our pleasure to have Dr. Khalid Mahmoud Sidi today with us. Dr. Khalid is neonatologist consultant and he's program director of Neonatal Perinatal Fellowship Program at Maternity and Children Hospital in King Salman bin Abdulaziz Medical City in Al-Madina, Al-Munawwara. Dr. Khalid was the former director of Maternity and Children Hospital in Al-Madina for 4 years. And Dr. Khalid interested, I think, in this topic. It's very too much. So I think this topic is very important for all of us, for any neonatologist, because it's really very risky and it's nightmare once the nurse called you because there's ET tube, there's blood in the ET tube, or the baby is suddenly static, or sudden deterioration, or mechanical ventilation, or without. So Dr. Khalid will talk today about this disease, neonatal pulmonary hemorrhage. تفضل دكتور خالد، شكرا جزيلا لوجودك معنا.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا. أود أن أشكر الجمعية SNS Saudi Neonatology Society for the invitation and give me the opportunity to participate with you. وعلى رأس البروف عبد الرحمن النمري. كذلك أشكر سعادتكم دكتور عدنان على الترتيب والتنظيم، جزاكم الله خير. Today our topic, as Dr. Adnan has mentioned, it's one of the life-threatening events, acute life-threatening events, and this is about neonatal pulmonary hemorrhage. I will start my presentation with the case scenario. 26 3-week gestation age boy, second day of life. He was born spontaneous preterm delivery after mom was unwell for 1 week with diarrhea and vomiting. The delivery was quick, and his baby had 1 dose of steroids 1 hour prior to birth. He received few inflation breaths, and he was transferred on mobile CPAP to an ICU. In the first 6 hours of life, his oxygen requirement increased, and his work of breathing also increased. And though the attending decided to give surfactant therapy through the LISA, less invasive surfactant administration. At 12 hours of age, the baby gets worse, increased more work of breathing, and the baby needed intubation and mechanical ventilation. Chest X-ray done and showed moderate to severe respiratory distress syndrome. At the end of the first day, he will start to have unstable blood pressure, needed normal saline bolus, and commenced on inotropic support. The second day of life, the baby, as Dr. Adnan mentioned, the baby suddenly deteriorated, and the nurse noted some blood in the endotracheal tube. This is the usual classical presentation of neonatal pulmonary hemorrhage. My outlines of the discussion today, I will discuss the recognized early signs and symptoms of pulmonary hemorrhage. I will try to describe the pathogenesis and the risk factors of pulmonary hemorrhage. Try to discuss the current option of therapy in the management of pulmonary hemorrhage. And finally, describe the outcome and prognosis. Pulmonary hemorrhage is a well-recognized condition in term and preterm baby that was first described as early as mid of 18th century, so something very old. It is typically an acute, catastrophic, often life-threatening event causing a sudden deterioration in the infant's clinical condition. Practically, the patient turns 180 degrees from being stable to critically sick. The incidence of pulmonary hemorrhage varies between 1 to 12 per 1,000 live births. It can be as high as 50 per 1,000 live births in high-risk group infants. The mortality rate can be as high as 50% in preterm infants, and it is present in 7 to 10% of all neonatal autopsies. And if we take VLBW, very low birth weight infants in particular, VLBW infant autopsies, it's up to 80% you can find evidence of pulmonary hemorrhage. Pulmonary hemorrhage occurs most commonly in the first few days after birth, and usually from the 2nd to the 4th day of life. Pathologically, it is defined as the presence of erythrocytes in the alveolar spaces interstitium, or both. But clinically, in the clinical practice, pulmonary hemorrhage defined as presence of hemorrhagic fluid in the upper respiratory tract or endotracheal tube that is accompanied by respiratory distress, which required escalation of respiratory support or introduction or intubation and mechanical ventilation. So we have to have the presence of hemorrhagic fluid in the ATT or in the upper airway. The baby is not intubated, ventilated. The baby getting worse respiratory-wise, and you found yourself with the baby on support that you are escalating the respiratory support. Massive pulmonary hemorrhage defined as that at least 2 loops of the lung are in full. This is the definition of the massive pulmonary hemorrhage. What are the maternal risk factors for the infant to develop pulmonary hemorrhage? Pregnancy-induced hypertension, one of the risk factors, toxemia, maternal infection, as well as bleeding disorders. Also, if the mother is on medication like anticonvulsant, antitubercle drug, or vitamin K antagonist, and also lack of antenatal steroid in preterm labor. What about the infant risk factors? It's a longer list. It started with, most importantly, is the prematurity. The more the premature baby, the more the risk of pulmonary hemorrhage. Prematurity, the most common risk factor. ELBW, infant, extreme low birth weight infant. IUGR, intrauterine growth restriction, baby with respiratory problem, hypoxia, ischemia, respiratory distress syndrome, meconium aspiration, pneumothorax, surfactant replacement therapy, also a risk factor to develop pulmonary hemorrhage, sepsis, mechanical ventilation, hemodynamically significant PDA or congestive heart failure, sign of disseminated intravascular coagulopathy, multiple birth, male gender, and hypothermia, as well as polycythemia, erythroplastosis peritalis, if the baby was on ECMO, the previous use of blood products, urea cycle defect, one of the risk factors that can present pulmonary hemorrhage, oxygen toxicity, rare causes like neonatal pulmonary hemosiderosis or airway hemangioma or hypoplastic lung disease. So there are a lot of risk factors. Berger et al. Published in Journal Neonatology in 2000, a case control study, and they found that antenatal corticosteroid has a protective effect. Barbara Schmidt in her study, the TIP trial, the trial of indomethacin from prophylaxis in preterm, pulmonary hemorrhage was among the short-term secondary outcomes studied, and they found no statistically significant differences was demonstrated between the indomethacin group and the placebo group. Prof. Khalid Saidy from King Khalid University Hospital published in Pediatrics 2008 post hoc analysis of the TIP trial, and he demonstrated that during the first week of prophylactic indomethacin reduced the risk of serious pulmonary hemorrhage by 35%. So indomethacin has a protective effect. And also furthermore, they added that baby who develop serious pulmonary hemorrhage, they have double the risk of death or survival with significant neurosensory impairment. So what is the size of the problem? How common it is, neonatal pulmonary hemorrhage? To answer this question, this is the best study that I found, published in the Archive Diseases, Fetal Neonatal Edition, 2018, by Dr. Ahmed Kashif. What they did, they use a population which is similar to the population that we are dealing with now. Widespread use of antenatal corticosteroids, also widespread use of surfactant replacement therapy. And they look at the association between early pulmonary hemorrhage and the major morbidities and mortalities in a large multi-center cohort in the USA. The cohort included all inborn infants from 340 pediatrics managed in ICUs within the USA, who were cared for from day of life 0 or 1 through death or discharge between 1st January 2005 till end of December 2014, i.e. over 10 years period. A total of almost a little bit shy of 600,000 infants cared for in the pediatrics associated in ICUs. Of these, around 3,000 or 2,800 infants had pulmonary hemorrhage as diagnosis. Among them, 1,476 infants less than 28 weeks. They were preterm and they had early pulmonary hemorrhage as diagnosis in the first week of life. Which of them, 1,363 were successfully matched with 2 controls, the same gestation age and sex. So this is this graph showing us the diagnosed pulmonary hemorrhage group, 1,363, and the control match 2 per 1 patient of them. And they look at the variable, they found only surfactant exposure. The baby developed pulmonary hemorrhage, they were having more exposure to proactant alpha surfactant compared to non-pulmonary hemorrhage, and the p-value was significant. Apart from that, there was no significant thing. The highest incidence of pulmonary hemorrhage to be among neonates between 23 to 24 weeks stations, with a pulmonary hemorrhage incidence can be as high as 87 to 86 per 1,000. And the incidence dropped dramatically over time with the gestation age. At 32 weeks gestation, it reached around 1.9 per 1,000. So among infants less than 28 weeks gestation at birth, pulmonary hemorrhage diagnosis was most common in the first day of life, 24% of them. Second day of life, 33% of them. And it starts declining thereafter through the first week of life. Beyond the first week of life, pulmonary hemorrhage occurred beyond the first week after birth in 19% of cases. So the incidence dropped dramatically. Okay, this graph table showing the difference between the pulmonary hemorrhage group and pulmonary hemorrhage regarding the patient characteristics. And we can look at those who develop pulmonary hemorrhage, they have high incidence of respiratory distress syndrome compared to the non, 96 to 93. They were developing more air leak syndrome, almost 10% compared to 7% in the non-pulmonary hemorrhage group. They had more grade 3 and 4 IVH compared to non-pulmonary hemorrhage group. And also they had more diagnosis as a shock or hypotension compared to the non-pulmonary hemorrhage group, as well as they have significant incidence of PDA compared to non-pulmonary hemorrhage group, as well as you know, the mortality at the first week, first month, and prior to discharge were all high compared to the match group. This Kaplan-Meier plot of survival through the first 50 days of the match sample, it showed that patients with pulmonary hemorrhage have significant excess mortality, which most prominent in the first 10 days of life. This is the group with pulmonary hemorrhage, and this is the survival of the baby without pulmonary hemorrhage. And this was also matched with which we discussed in the first table, that the mortality in the first week of life, almost 40% in the pulmonary hemorrhage group, compared almost 20% in the non-pulmonary hemorrhage group, as well as in the first month, 54% compared to 29%, and 57% prior to discharge compared to 33%. Definitely the incidence, the case of pulmonary hemorrhage has high mortality and morbidity. Okay, those who had pulmonary hemorrhage and survived, compare them to those who did not make it and died. What is the major differences there? This is the group who make it, survive, 588, and this is the one who died, succumbed secondary to pulmonary hemorrhage, 775. And what they found, they have more antenatal corticosteroid exposure to those who did not make it, and they were older in gestation age, 25 compared to 24, and also heavier, around 800 compared to 600 or 700 grams. Also, they found that they needed less inotropes compared to those who did not make it, as well as grade 4 was less, and those who survived, 12%, or compared to those who did not make it, around 27%. The incidence of PDA was more common in those who survived. So it means pulmonary hemorrhage related to the PDA, it is treatable with high chance of survival compared to those who did not have significant PDA. Okay, now move to the pathogenesis or pathophysiology of the pulmonary hemorrhage in newborn. The exact pathogenesis of pulmonary hemorrhage remains unknown in the newborn. And the most cases of pulmonary hemorrhage actually secondary to hemorrhagic pulmonary edema rather than a true bleed. And the evidence for that, the hematocrit of the pulmonary hemorrhage fluid is 15–20% less than the whole blood hematocrit. So it is not real bleed. Several theories exist to explain the pulmonary hemorrhage in neonates. We'll try to go over them. Cole et al. Published in Pediatrics 1973 his theory of hypoxia and acidosis as causing acute left ventricular failure. This will lead to elevation of pulmonary capillary pressure, and that will lead to the sudden influx of hemorrhagic pulmonary edema fluid into alveoli, and this will present like pulmonary hemorrhage. The second theory is the stress theory by West et al., published in 1992 in The Lancet. His theory is behind that there is stress failure of the pulmonary capillaries, leading to the breakage in the endothelial barrier, leading to the leakage of the hemorrhagic fluid into alveoli and presentation with pulmonary hemorrhage. The most popular and currently acceptable theory is the PDA. The PDA, as you know, with decreasing pulmonary vascular resistance, there is significant increased left-right shunting to the ductus arteriosus, and this will lead to increased more pulmonary blood flow to the lung, and this will lead to the pulmonary hemorrhage. What is the relation between surfactant and pulmonary hemorrhage? As you know, surfactant improves the lung compliance and decrease pulmonary vascular resistance. This will lead to increased left-right shunting through duct and others, and this will lead to the pulmonary hemorrhage. So Sol et al. Published in Cochrane database of systematic reviews in 2010. Cochrane's systematic review of 7 randomized controlled trials. In total, number of babies were 1,583 premature infants. And they concluded that prophylactic treatment with protein-free synthetic surfactant increased the risk of PDA of a risk ratio of 1.11 and 90% confidence interval ranging between 1 to 1.22. And pulmonary hemorrhage risk increased to 3.28, 95% confidence interval ranging between 1.5 to 7.16. I would like to underline the word prophylactic treatment, and this was an old recommendation to give surfactant prophylactically, sometimes even in the DR. Bandit and Pediatrics 1995, they published their case control study in almost 800 LBW neonates treated with surfactant, found that 94 babies, i.e. 12% of the population, developed pulmonary hemorrhage. It was associated with increased risk of death. The odd ratio was 7.8, 95% confidence interval 2.6 to 28, and the short-term morbidity in moderate to severe pulmonary hemorrhage were 4.4, with the 95% confidence interval between 1.3 to 15.7. So what is the clinical presentation of baby with pulmonary hemorrhage? Back to the scenario that we presented our presentation with, fresh blood oozing from the nose and the mouth, or from the endotracheal tube if the baby is mechanically intubated and ventilated. That followed by frothy pink-tinged secretion, are commonly followed by fresh bloody secretion coming from, and worsening of the respiratory status, as well as rapid clinical deterioration in the form of apnea, cyanosis, hypertension, and poor systemic perfusion. Of course, with the digital X-ray, there will be abnormal radiographic findings, and the baby will be in a state of hypovolemic shock and anemia. And of course, feeding evidence of DIC bleeding from other side. This X-ray initially it can be normal, then with pulmonary hemorrhage can give you a fluffy appearance, can be as worse as homogeneous opacities of both lungs and can be as white out lung disease. If you do echocardiography, you found significant hemodynamic signals that PDA with left to right shunting. What is your differential diagnosis? Direct trauma to the airway due to intubation, vigorous suctioning, or bag and mask ventilation. This could be a possibility. The second possibility, this blood is actually it's a maternal blood and aspirated during the process of labor. How to investigate baby with pulmonary hemorrhage? We do CBC with differential, looking at evidence of anemia, thrombocytopenia. We do coagulation profile, looking for evidence of DIC or coagulopathy. Arterial blood gas, looking for if there is evidence of hypoxemia or there is acid-base imbalance. UP test is used to if the suspicion of the maternal aspiration of maternal blood is suspected, and hematocrit of the aspirate may differentiate between the true hemorrhagic fluid and hemorrhagic edema, pulmonary edema. And finally, ammonia to rule out the role of unicycle defects. The management of pulmonary hemorrhage, basically, the goal of the management are mainly supportive. Your target is to control and stop the bleeding. You try to optimize the oxygenation and gas exchange. And finally, to identify and treat the underlying etiology. So basically, you have to start with immediate management. ABC should be included, including the intensive care centered around the maintenance of the airway patency. You have to have adequate breathing, improve circulation, including suctioning in tracheal tube, mechanical ventilation, resuscitation fluid, nutrition support, and sedation. Optimize oxygenation as guided by pulse oximetry, and positive pressure ventilation in the form of increasing peak in expiratory pressure. It has a tamponading effect, and hopefully this will minimize further bleeding, increase manual pressure, and maybe you consider HFO, high frequency ventilation. Now, if we look at the evidence, the level of the evidence of the treatment management of pulmonary hemorrhage in the newborn, what most of our evidence coming, unfortunately, from the cohort study and case control study. We don't have a good randomized control trial study that examined this point. The best evidence I could find is in published September 2021, published in the Acta Pediatrica. This is a pulmonary hemorrhage in neonate, a systematic review of the management only. And what they did, they used the PRISMA, the preferred reporting items of systematic review and meta-analysis guidelines, and the search from 1975 up to 2020 for any management evidence of management and neonatal pulmonary hemorrhage. They included 16 studies, a total of around 400 patients were included in the systematic review. The treatment of pulmonary hemorrhage was examined under the following outcomes. Number one, cessation of pulmonary hemorrhage. What management could control the pulmonary hemorrhage? Number two, what does improve the oxygenation or improvement of the oxygen index? And three, recurrence of pulmonary hemorrhage. And finally, the mortality and long-term disability. The adjunctive treatment were also commonly used. So it's not only sole management, they give more than one. So the adjunctive therapy can be assessed prior to, concurrent with, or following the primary treatment. So this is also being considered. The first therapy that was examined is the surfactant. What is the role of surfactant and pulmonary hemorrhage? And here there were 3 trials by Dr. Abdulaziz and his group, and to do surfactant for pulmonary hemorrhage in neonate, a Cochrane review done. First one was in 2007, 2012, and the final one was in the February 2020. Unfortunately, they could not predict. Paradoxically, there is some suggestion that surfactant may be used to successfully treat pulmonary hemorrhage, although Cochrane review found no randomized or quasi-randomized trial that would allow a firm conclusion to be reached. So there is no randomized control trial, as you mentioned, Ed. These are the evidence from the systematic review. They look at different studies, and they collectively, if you look at our studies, it's a case report, for example, here, one patient, level 4 of And this one prospective RCT 42 baby. And this is the level of evidence was level 1B case report. So very small number of baby and very short. This is for examining of surfactant therapy on. And in 5 studies in which surfactant was the primary, we found that it will be effective both in inducing cessation of pulmonary hemorrhage as well as improving the oxygenation measures. Endotracheal tube adrenaline was used as adjunctive therapy to primary surfactant therapy. So surfactant was given as well as endotracheal tube adrenaline as adjunctive therapy. The type of surfactant had no effect on the mortality rate or long-term disability. And finally, recurrence of pulmonary hemorrhage did not occur in any of the 5 studies that used surfactant as a primary treatment method. So apparently surfactant is very effective as a primary management for pulmonary hemorrhage. Number 2, ventilation. What is the role of ventilation? And these are the studies that have been included. If you sum them up together, small number size, 86 patients, and what they conclude. High frequency oscillatory ventilation and intermittent positive pressure ventilation were commonly used as a primary treatment method. Oxygenation index showed rapid and significant improvement following 1 hour of high frequency oscillatory ventilation use and subsequent continued improvement in those infants who responded. It has been concluded that HFO was safe and effective adjunctive rescue treatment for neonates with pulmonary hemorrhage or other types of respiratory distress following the failure of conventional mechanical ventilation. It has been noted that an improvement in the venous blood gas and oxygenation index following the infant receiving adjunctive PEEP, positive end expiratory pressure ventilation therapy. Just suppose going back to our local experience, Prof. Turkil Al-Harfi published his the local experience in American Journal of Neonatology long time back, 2004, under the title of High Frequency Ventilation in the Management of Pulmonary Hemorrhage. It was a study in King Khalid University Hospital in ICU between January 1993 and December 1996. Among 243 VLBW infants admitted to their unit in the study 4 years, 27, which is around 11%, had pulmonary hemorrhage. Of those, 9% had massive pulmonary hemorrhage. In this group, almost 91 of them had severe respiratory failure, required high-frequency ventilation. And he examined this and looked at these are the patient characteristics. They were all, this is the responder to high frequency, the non-responder, they were comparable in all aspects. When they start, and this table also showing the respiratory characteristics pre and 3 hours post-intervention. Their alveolar arterial ratio and oxygen index. For those who responded, there was significant improvement. OI from 26 dropped all the way to 16. In those non-responders, there was no significant changes. And he concluded that these results shows that HF high-frequency ventilation can facilitate adequate gas exchange in critically ill neonates with massive pulmonary hemorrhage and respiratory failure, and hence may improve their survival. By the way, did not use high-frequency oscillatory ventilation. They were using infant start ventilator in this study, and this is one of the high-frequency flow interrupters. Third modalities of treatment options is epinephrine. And these are the study that the systematic review that discussed the epinephrine role in the management of pulmonary hemorrhage. And they conclude that ETT adrenaline was the primary treatment method to utilize its effect of vasoconstriction as well as increasing the cardiac output for resuscitation and cessation of pulmonary hemorrhage. Pulmonary hemorrhage was stopped in the most neonates following administration of 3 to 5 doses of 0.5 ml of ETT epinephrine 1 in 10,000. This method was not only effective in treating pulmonary hemorrhage, but also avoided unnecessary use of endotracheal suctioning. The fourth management is the coagulopathy, management of coagulopathy, which is commonly described in conjunction with pulmonary hemorrhage. Vitamin K was administered in combination with the vasopressor for all neonates studied, evaluated with the effectiveness of administration of vitamin K or vasopressor in inducing cessation of pulmonary hemorrhage or achieving favorable outcome, as well as blood products. Of course, baby bleeding, give him blood, FFP, fresh frozen plasma, red blood cells, platelets as needed. The activated recombinant factor 7 works, as you know, activating the extrinsic pathway and binds to the tissue factor, which leads ultimately to the production of fibrinogen fibrin clot, which seal the site of the injury and cause vascular repair. The effect is enhanced with the platelets are co-administered. It has been used with the cessation of pulmonary hemorrhage and return to normal hemostasis was achieved. Novocaine, increasing the prothrombin activity in a dose-dependent fashion, thus leading to formation of fibrin clot. It has been reported that it can cause cerebral venous thrombosis as a potential complication in adults, but nothing mentioned in newborn about this. And these are the studies that have included used Novo7 as treatment options in case of massive pulmonary hemorrhage. Hemicoagulase is another medication, which is a newer treatment option. It's derived from the Brazilian snake venom. It is thromboplastin-like effect that converts prothrombin to thrombin and fibrinogen to fibrin. The dose is ranging, of course, this is from the clinical trial, 0.5 Ku through the endotracheal tube every 4 to 6 hours till the hemorrhage stops. And these are the clinical trials that have used hemicoagulase in the treatment management option. Administered through the endotracheal tube, hemicoagulase to 28 preterm neonates with pulmonary hemorrhage, and it showed reducing the length of pulmonary hemorrhage, the duration of mechanical ventilation, as well as there was also significant reduction in the mortality between the hemicoagulase group and the control group. So apparently it is effective, but still I think we need more evidence for that. Finally, the long-term neurodevelopmental outcome for the babies who develop pulmonary hemorrhage. And we have also limited evidence. In this prospective case control study, they were more predisposed to develop periventricular leukomalacia, 17% compared to 0 in the control group. And they found that the mean mental and psychomotor developmental indices to be non-significantly lower among the infants who survive pulmonary hemorrhage. This table summarizes the whole thing. So the role of surfactant, yes, it does stop the bleeding, improve the oxygenation index, prevent recurrence of the bleeding, and hopefully decrease mortality and chronic lung disease. Ventilation, it has almost the same effect. Epinephrine with endotracheal tube also improve this, stop the bleeding, improve the oxygenation, decrease or prevent recurrence, and hopefully decrease disease. The coagulopathy recombinant factor 7, we didn't know anything much about the rest because it was only a case report. Hemicoagulase also limited experience with it. So the keynotes of the presentation of this systematic review exist to outline the best management option for neonatal pulmonary hemorrhage. And this study discovered that while multiple treatments are used, a multi-system approach is crucial, involving ventilation, resistant monitoring, appropriate use of eye intervention, such as surfactant therapy, high-frequency oscillatory ventilation, and increased mean air pressure. Further randomized control trials will be essential to further deduce the most effective management of neonatal pulmonary hemorrhage. This is the take-home messages from my presentation. Pulmonary hemorrhage is a life-threatening condition, catastrophic event, which is associated with high mortality rate in neonates. A multi-system approach is crucial, involving adequate ventilation, resistant monitoring, and surfactant therapy. surfactant therapy was the most cited approach, although the timing of the administration, the number of doses required to achieve the optimal outcome is still debatable. The evidence support that surfactant use as the treatment for pulmonary hemorrhage is associated with reduced mortality, stop the bleeding, and improve the oxygenation, regardless of the type of natural surfactant administered. HFO, high-frequency isolated ventilation, has also shown efficacy. HFO has also shown efficacy in improving oxygenation index. Understanding the etiology of pulmonary hemorrhage and optimal standardized management of coagulopathy and circulatory failure are vital to improve the outcome by preventive and rescue measures. And thank you very much for listening.
شكرا جزيلا دكتور خالد. Thank you very much. بصراحة محاضرة رائعة ومعلومات جدا مهمة and extensive review of the literature of pulmonary hemorrhage. I don't know if Prof. Nimri has any comment. He raised his hand before. تفضل بروف.
شكرا جزيلا دكتور خالد، لا حرمنا الله فضلك ولا علمك ولا سمتك، زادك الله علما. دكتور خالد، السؤال اللي دائما ديبيتابل وتلاقي كل اليونت وممكن معظم الاتندنز الان من الفيلوز بيسالونا عن السؤال هذا. احنا we know this is a PDA related pulmonary hemorrhage in the majority of cases. Agree? Agree. At that moment, shall I start treating the PDA? بمعنى shall I start the indomethacin, restricting the fluid, although the baby is hypovolemic from the shock, from the bleeding? Shall I restrict the fluid, or shall I give him more fluid, which make the PDA further? So what is the situation of the fellows at that night with the PDA? Can he treat it? Well, time now to save the baby from the ventilation, as I mentioned, adrenaline, surfactant, وبعدين نفكر في البداية. شكرا جزيلا.
عفوا، شكرا دكتور. I think this is a good question. The answer is, first of all, as we discussed in the presentation, you have to stabilize the baby. Now his baby in acute life-threatening condition. You are talking about he is deoxygenating, he's desatting, he's hypoxic, he's hypotensive, he's in shock state, acidotic. So I think here the priority goes for you have to normalize all his physiology, normalize his oxygenation, to open the airway, suction the endotracheal tube. If there is blood in the endotracheal, improve his oxygenation, move the chest, let the chest move, and improve his oxygenation. And hopefully with this, if you normalize his oxygenation and there no more further bleeding, you can give surfactant to improve his oxygenations, as well as gas exchange, normalize his fluid, maybe resuscitation fluid, normal saline. If the blood pressure is not improving and still baby is hypertensive, we consider inotropic support. So now this is the acute management. Now here it is emergency. I think the role of the PDA management, I don't think it's a priority here now. Now our priority is to ABC, the airway, breathing, and circulation. Now if you normalize his oxygenation, as you know, you have to improve this, and then you can assess the baby and look the underlying cause. Is it related to the sepsis? Is it a PDA related? Is this something else? There was this baby in a state of DIC state, or had coagulopathy that make him at high risk of pulmonary hemorrhage. And then I think we should discuss that. But I think the primary management is acute management and normal and stabilization of the baby. Then you can consider PDA management and other things.
Dr. Khalid. We have some question in Q&A.
Yes,
First
please.
question is how to manage pulmonary hemorrhage with patient with tracheoesophageal atresia repaired.
Repaired.
Yeah.
And the same. The issue here is that you should try your best not to hyperextend the neck, because especially we just had operation a couple of days ago and still the healing process is not yet intact. Just try to not to overextend the neck, and try to maintain the patency of endotracheal tube, suction, increase your PEEP, give epinephrine through ETT, give surfactant, stabilize his resuscitation fluid, give fluid, and normalize his blood pressure. Follow, of course, monitor his acid-base status, make sure that he's not acidotic, improve his oxygenation, The same thing. I don't think there is anything different. If the baby had surgery, if he had surgery, then try to avoid hyperextension to avoid, not increasing the chance of the break of the surgery side. But if he did not had surgery, then you go ahead and treat him as you are treating baby without the tracheoesophageal fistula. Because the risk here is that with pulmonary hemorrhage, the blood will come. If there is tracheoesophageal fistula, most of the blood will go to either come to the endotracheal tube, to the ETT, or come to the fistula, going to the gut, to the stomach. So I think there is no big deal in the management. It will be the same regardless. But the only drawback here, if the baby had surgery, the same 1 day, 2 days back, and here you have to avoid hyperextension of the neck during the trial. If the tube need to be changed, you have to be very careful in reintubating him.
The second question, Dr. Khalid, which is more effective, epinephrine administration, direct or in the ET tube or nebulization?
Nebulization, I am afraid, there is no way. I did not come across any evidence through the nebulization or through the endotracheal tube. Because nebulization, how it will be nebulized in the endotracheal tube and how much it will be get in. Because this baby, most of those babies need to be ventilated, and you have to secure the airway. And if the baby has a significant pulmonary hemorrhage, I don't think you have to give him bag and mask ventilation or face mask or nasopharyngeal SIMV and waiting for it. I think you have to secure the airway and make it sure it's taken. So most of the study are giving endotracheal tube through the through the ET, not through the nebulization.
The next question is, surfactant was beneficial in treatment of severe pulmonary hemorrhage. The question is, what is the recommended number of doses and what is the recommended frequency?
This question is still open. We don't have evidence to answer this question. And this one of the recommendation of the of the systematic review, that they need to know the frequency of the dosing. Apparently, all the natural surfactants are effective, all of them. I'm not talking about prophylactic. Prophylactic surfactant is increasing the risk of the pulmonary hemorrhage. And this has been now since 2013, since the initiation of CPAP's early management of the LBW babies. I think where the use of surfactant or prophylactic surfactant has been decreased. And now we're talking about all the natural surfactants are effective in what is the dosing and the frequency. Is still it's debatable because we don't have evidence for this. I think you should give, according to your hospital policy, you give it and then wait for a response and monitor your baby. Maybe you give 2 or 3 or 4 doses till you found some response and improvement of oxygenation and ventilation.
Next question from Dr. Tajuddin Ali. I don't know if it's he's asking or answering that the dose of surfactant in pulmonary hemorrhage higher than other conditions, 6 ml per kg. So I don't know if he's asking or he's giving the dose. It's not clear for me.
I think this is his comment.
Is there any difference in the dose, Dr. Khalid? Or is it regular?
I did not come across any increased dose.
Okay. Next question. Is there any rule for prophylaxis, AT tube, epinephrine, or FFP?
Prophylactic. The problem with pulmonary hemorrhage is that you cannot predict which baby will have.
Yeah, sure. Yeah.
So how you can give prophylactic for something that you
otherwise we'll give for all premature babies.
Exactly. The same thing for IVH and FFB and this. The same concept of people thinking about if they give FFB, you will decrease the risk of IVH, to decrease the risk of pulmonary hemorrhage. The problem, this is unpredictable. And I don't think there is no evidence, at least there is no evidence, I did not come across any evidence that there is a role of FFB in minimizing or preventing the incidence of pulmonary hemorrhage in newborn.
Same questions repeated regarding instead of Surfactant, the number of doses of epinephrine in case of pulmonary hemorrhage.
As you said, you can give as much as we need. The epinephrine has 2 effects, as we mentioned in our talk. It gives vasoconstrictive effects, hopefully will minimize the bleeding and also improve the cardiac output to improve the oxygenation and tissue oxygenation perfusion. And you give first dose, second dose till no more further bleeding comes and the baby stabilizes.
Next question by Dr. Youssef. Is there any rule for conventional mechanical ventilation? If any, what is the recommended initial setting of conventional mechanical ventilation in case of pulmonary hemorrhage?
Actually, both the high-frequency ventilation as well as the conventional ventilation, both are effective in the management of pulmonary hemorrhage. But apparently, there is more more publication regarding the role of the HFO, high-frequency oscillator ventilation, more because it has increased mean air pressure, and you are inflating the lung to some certain stage, and then you oscillation around. This may be giving a more tympanotic effect, minimizing the bleed. But even the conventional ventilation, it is very effective. But here you have to consider going up with your PEEP, positive end expiratory pressure, beyond the normal to have, as we discussed in the talk, tympanotic effect, minimizing the bleeding from the alveoli. But both are effective.
Another question from Dr. Tajuddin, the role of diuretics in treatment of pulmonary hemorrhage.
Diuretics, yes, it has a role, but this is for not in acute management stage, maybe later on if you found your PDA is increasing the risk of pulmonary blood flow and your lung is wet, then you, of course, after echocardiographic assessment, then you can consider diuretics. Yes, you're right.
There's another question, I think it's a very important question from Dr. Shaima. That's after we give the Surfactant or Epinephrine for the pulmonary hemorrhage, when we can do suction.
It is very important to keep the patency of the airway. Please remember A, B, C. You have to keep your airway patent. Even if there is some blood or there is blood and the chest is not moving, you have to increase your suction and you have to remove the secretion on a blood clot from your tracheal tube. Without proper ventilation, you're not going to get any good cardiac output and the rest of the thing. So patency of the ATT is a must. Yes, some people trying to minimize suctioning. If the baby is not, if the chest is moving and baby ventilating and respiration is fine, and there is something of blood here and there, it's okay, I will not mind. But if the chest is not moving, no, I have to get this chest moving. So suctioning is needed as needed. I mean, when it is important, you have to do it.
I think we don't have any other question. Thank you very much. Thanks all for attending. شكرا جزيلا دكتور خالد.
لو سمحت لي بس عدنان
تفضل
بس على الوضع. احنا يمكن تكون هذه مش نهاية انما the last 2 weekly activity، لان احنا فتحنا الان النيوناتولوجي كلاب all over the kingdom بكل فروع الجمعية، سواء كان في الغربية، في الشمال، في الجنوب، في الشرقية. الرياض بكرة عندنا بداية الكلابس. فمع وجود الكلابز هذه انا اقترحت على الدكتور عدنان، واللي اقترح لكم انتم يعني تجتمعوا كمجموعه as a fellows مع your program directors وتسي مع عدنان وتسي what is the best timing. Is it monthly, every 2 weeks, how we can adjust. لان انا احتاج منكم حضوركم في الكلابز هذه، لان الكلابز هذه لكم او منكم واليكم زي ما يقولون. فاتمنى من الجميع الحضور، وشكرا دكتور خالد، شكرا لك دكتور عدنان، وكلها في ميزان حسناتك بإذن الله تعالى.
شكرا جزيلا بروف، شكرا جزيلا دكتور خالد، شكرا جزيلا جميع الأخوة على الحضور. نلقاكم على خير إن شاء الله تعالى.
السلام عليكم.